Next we have Dr. Joe Phillips sir, who is a medical director at Ottapalam Eye Care Hospital, trained at Medical College Calicut and has worked at Angamali Little Flower Hospital. So he's going to cover capsulorhexis and hydroprocedures.
So good morning everyone. So I'll be covering these three topics. If your capsulorhexis is not right, all the subsequent steps of phaco is going to be difficult and going to be extremely risky. And you have only one chance to get it right. So I prefer to use the forceps for capsulorhexis, which has markings 2.5 and 5 millimeter markings, so that I can measure the rhexis. But the needle cystotome is also fine. So how I do the forceps, the rhexis with the forceps, I first mentally plan the rhexis, the centration, how it has to be centered and the size. And first I make a small incision on the center of the anterior capsule and I extend it for about 2.5 millimeters. Then I grasp the edge of the capsule and lift a flap. And the next step is to start the curve. So the most important point is not to use the edge of the pupil as a reference, because that may cause an oversizing of the rhexis. So you have to learn to pivot the forceps within the tunnel, avoid applying pressure on the tunnel. That will cause leakage of visco and collapse of the anterior chamber. So the trick here is to move the tip of the forceps in a circle, because the flap will always follow the tip. So if you move it in a circle, you will get a nice round capsulorhexis. So coming to the last grab, you don't pull the flap into the center, just continue the curve and make it as round as possible. Now, rhexis with the cystotome, you enter through the paracentesis, again make a small incision in the center and extend the tear for about 2.5 millimeters. And here the friction between the tip of the forceps is used to push the flap in a circle. So you should always keep the force in a tangential way, so that a shear force is created at the edge, so that it doesn't rip the tear. And sometimes the flap will float up and you have to keep pushing visco into the chamber so that you keep the flap down on the anterior lens surface. So with the cystotome you can maintain the chamber better because it is done through a smaller incision. And towards the end, you just continue the curve and don't pull the flap towards the center. Just continue the curve and make it again as round as possible. And also focus on making it well centered. That is very essential when you're doing a phaco surgery. Now, this is a technique called little technique, that is to rescue a run-out capsulorhexis. So it is first described by Dr. Brian Little at Moorfields Eye Hospital. So I'm halfway through the rhexis using a cystotome, and at some point the patient was not fixing properly, so I lost control of the rhexis and it has started to run out. So at this point, you immediately stop the rhexis. Do not continue the rhexis. Push visco into the chamber, so to flatten the anterior chamber. So it reduces the pressure, the posterior pressure from the vitreous and the lens on the anterior lens capsule. And then the next step is very crucial. You pull the flap towards the center. So this is the direction. You pull it toward the center. This creates a vector force which will redirect the flap back to towards the center. And then you can complete the rhexis more carefully. So it's a very important technique. You should always remember this. And in some cases, you may have to enlarge the rhexis. So here the IOL has already been implanted. The rhexis was slightly undersized, so I thought of making it a little more larger and uniform. So first make an oblique cut, a small oblique cut in the on the capsule, and then with the forceps, I'm slowly trying to enlarge the rhexis. So it's important not to extend the tear. I mean, if you're not careful, it might extend and create more problems. And in some cases, you may have to do this before the nucleus delivery so that you can safely remove the nucleus. So this is the end of the case, and you can see a uniform 360-degree overlap of the anterior capsule. Now coming to hydroprocedures. So hydrodissection, it separates the nucleus from the capsule and helps to rotate the nucleus. And hydrodelineation separates the epinucleus from the endonucleus, thus creating a barrier between the nucleus and the posterior capsule. Now, hydrodelineation is not always necessary and may not be always possible, especially in a dense nucleus. And probably the only indication is in a posterior polar cataract where hydrodissection is contraindicated. So here, using a hydrodissection cannula, you go under the capsule towards the periphery, just tend the capsule a little bit and gently push BSS. Now you can see the hydrodissection wave, tap the nucleus and the nucleus is now freely rotating. And with the same cannula, you can go into the substance of the nucleus, between the epinucleus and the endonucleus, and gently push the BSS, and then you can get the delineation. So now you can see how the nucleus is clearly delineated and is easy to rotate. Now just to show the epinucleus, so the last phaco piece is being emulsified, and you can see the epinucleus behind it, creating a barrier between the nucleus and the capsule, making it safe for phaco. So nucleus rotation. So this is not a very dense nucleus, just 1 or 2 points of hydrodissection, and the nucleus freely rotates with just the movement of the cannula itself. When you have a more denser cataract, there are more corticocapsular adhesions, so you will need a Sinski hook to rotate the nucleus. So rotation initially is a little slow, then it becomes faster. So you can turn the nucleus in both directions few times so that the nucleus spins easily both ways. And this was a case where there were dense corticocapsular adhesions. So I had to separate I had to break the adhesions by using an iris repositor. This has to be done all around, 360 degrees. And then it was a very small rhexis, so I had to enlarge the rhexis, do the hydrodissection, and then the nucleus would rotate. And lastly, you can get very mature or hypermature cataracts where you don't need any procedures to rotate the nucleus, it simply rotates in the back. So thank you, and thank you, Dr. Alex and the scientific committee for giving me this opportunity.